இந்த மெடிசன் GLP, அப்புறம் Mounjaro, அப்புறம் அந்த Ozempic, I think there are another 2-3 other medicines are coming up now. இது என்ன மெடிசன், இதை வந்து யார் எடுக்கலாம், ஃபஸ்ட்டு இது யாருக்காக கண்டுபிடிச்சது?
The good part is these drugs are game changers. There's no doubt about it.
மக்களே சிக்ஸ் பேக் தெரியல அப்படின்றதுக்காக GLP, Mounjaro இதெல்லாம் எடுக்கிறீங்க அப்படின்னா உங்களுக்கு மசில் லாஸ் தான் ஆகும். இதை நல்லா கேட்டுக்கங்க.
Absolutely. If they are not going to do any lifestyle modification, if they are not going to stick to a good nutrition, if they're not going to exercise, this is absolutely useless because once you stop, you're going to gain back all the weight.
Women, especially post-40s, who've been struggling with menopause, severe menopause. Can this drug help them? Welcome to another video with Battle Bros, and our special guest is here, Dr. Arun Raghavan. He is an expert in Diabetologist, and also he's a co-founder of Revivo Clinic. So, Doctor, first direct question குள்ள போயிரோம். இந்த medicine GLP, அப்புறம் Mounjaro, அப்புறம் அந்த Ozempic, I think there are another 2-3 other medicines are coming up now. இது என்ன மெடிசன், இதை வந்து யார் எடுக்கலாம், ஃபஸ்ட்டு இது யாருக்காக கண்டுபிடிச்சது?
Thank you, Nick. Thank you very much for the opportunity to be discussing with you. So firstly, I think GLP-1 receptor agonists have exploded. They've captured everyone's imagination. Today, I see patients actually asking for a drug like Mounjaro or Ozempic. This has never happened to me before. Patients coming with trade names of drugs, right? We tell patients, இப்படி ஒரு மருந்து பேர் இன்னைக்கு வந்து ரிவர்ஸாக போயிட்டுருக்கு. Patients வந்து கேட்குறாங்க. So there is a good side to it. There is also a flip side to it. Let me first tell you the good part. The good part is these drugs are game changers. There's no doubt about it because anti-obesity medicines have been there for decades. The maximum of weight loss which was achieved by earlier group of medicines was about 1.5 to 2 kgs at best. And what used to happen, there used to be some adverse effect in the drugs used to be banned. This was the history of anti-obesity medicines over the last several decades. However, GLP-1 receptor agonists, I've been giving GLP-1 receptor agonists for the past 15-16 years since they have been conceptualized and introduced. However, these agents were anti-diabetic agents. They were used predominantly for only controlling blood sugar. The additional advantage was weight loss. But the last 5 years in randomized control trials, they were used regardless of diabetes, and the results were profound weight reduction, right? Without hypoglycemia, without low sugars, even in people without diabetes. So that's how these agents caught everyone's attention and they kind of became blockbuster drugs. So we have enough and more data. These drugs were studied in multi-billion studies like RCTs. So post-marketing trials also, including real-world scenarios, there is enough evidence to show that they cause good amount of weight reduction. You're talking about 15%, 20%. Like Nick pointed out, the newer molecules, we have the retatrutide, it is breaching around 30 to 35%, which is going into the metabolic surgery, the bariatric surgery kind of limits, which means surgery for obesity is going to be a thing of the past. So that's the kind of game changers that these agents have been.
ஓகே, ஸோ இந்த மாதிரி இப்போ Ozempic, Mounjaro இப்படி இருக்கும்போது, ஸோ இஸ் இட் எக்ஸாக்ட்லி த சேம் ஆர் இஸ் தேர் எனி டிஃப்ரென்ஸ்? லைக் இந்த பர்சனுக்கு இது செட் ஆகும், இல்லை இது காமனாக ரெண்டுமே யார் வேணாலும் எடுக்கலாம் அப்படின்ற மாதிரி ஏதாவது ஸ்பெசிஃபிக் க்ரைட்டீரியாஸ் இருக்கா?
Excellent question. So that's the thing, because now what I see is these agents are being overused, and some of patients who perhaps do not require at all are also ending up using these agents. That should be avoided. Now, there are multiple differences between both these agents. One is a pure GLP-1, which is semaglutide. The Mounjaro is actually tirzepatide, is a twin creatine, which is GLP-1 and GIP together. So it has 2 incretin hormones. So that's why we see Mounjaro having a little edge over semaglutide in terms of weight loss benefit. However, semaglutide also has its advantage because it has now recently been approved by the US FDA for fatty liver. There is no drug as such in India for fatty liver approval except for a drug which is called saraglitazole, which is a very weak action. But this drug reduces fat because fatty liver la main வந்து கொழுப்புனால தான். Once weight starts coming down, the fatty liver also improves. So that has been approved by the US FDA. The labeling indication in India is awaited. It should happen anytime soon. So people with fatty liver, and another RCT demonstrated that patients who have cardiovascular risk, who are obese, it's called the SELECT trial, semaglutide reduced cardiovascular mortality by 20%. That is again unbelievable results, because one part is weight reduction, but why do we need to reduce the weight? To finally make him or her live longer, right? So 20% was the mortality risk reduction with semaglutide. So person who's got comorbidities along with obesity, there are certain risk factors to assess the cardiovascular risk. Suppose somebody has got that, then semaglutide has an edge. But no comorbidities, only pure weight, then I would probably say tirzepatide has an edge over semaglutide. There are other subtle differences, but then they have to be individualized based on patient's profile, blood workup, so on and so forth. But these are the broad differences as I highlighted.
டாக்டர் இப்போது நான் ஒரு சிம்பிளாக ஒரு லேமன் புரிஞ்சுக்கிற மாதிரி இந்த ட்ரக் எடுக்கிறாங்க, இந்த ட்ரக் உடம்புல என்ன பண்ணுது, ஆக்சுவலாக எப்படி வெயிட் குறையுது?
Okay, so largely we all know that recently we've been seeing in social media it suppresses the appetite. Everybody's talking about GLP-1, right? It does suppress the appetite, but emerging evidence, is more and more evidence is showing that it also actually works on the reward center. Basically, like we've seen some people, right? Some people, they have certain tendency to overeat. They have cravings also, right? Now, over the years, if you look at it, food itself gives us a lot of pleasure, reward. That center itself kind of is hit by the drug, and the craving and urge to eat itself is mitigated. That is also one of the main actions of these GLP-1s, apart from, of course, acting on the hypothalamus of the brain, which reduces the person's appetite and also reduces the gastric emptying. So நம்ம சாப்பிட்ட சாப்பாடு வயிறில் கொஞ்சம் நேரம் இன்னும் இருக்கும். ஸோ அதுவே ஒரு ஃபுல்னஸ் கொடுக்கும். டைஜஷன் ஸ்லோ ஆகிறனால பசி டக்கு டக்குன்னு எடுக்காது. அது ஒரு விஷயம். ப்ளஸ் நமக்கு அந்த கிரேவிங்ஸ், எஸ்பெஷலி தேர் ஆர் சர்டன் ஜீன்ஸ் which are culprits for certain people who are very obese. The genetic testing is not recommended by any agency because it is extremely expensive. So it is not recommended routinely. There is the FTO gene. But these people actually have a tendency to overeat. They have such cravings. That's also kind of addressed, and they don't have that craving anymore. They're able to make smarter food choices.
Okay, so if appetite reduce பண்ணது அப்படின்னா, ஃபார் எக்ஸாம்பிள் இஃப் வி வாண்ட் டு சேஞ்ச் தி ஃபுட் சைக்கிள், ஒரு டைம் மீலை வந்து நாங்கள் அவாய்ட் பண்ணோம்னா ஃபஸ்ட் ஒரு 2-3 days வந்து பசி ஜாஸ்தியாக இருக்கும், அதுக்கப்புறம் அந்த டைமில் பசிக்காது. ஸோ இந்த மாதிரி கேசஸில் லைக் இந்த மாதிரி appetite ரெடியூஸ் பண்ணும் போது பிகாஸ் ஆஃப் தட் மெடிசன், ஆஃப்டர் வி கம்ப்ளீட் தட் சைக்கிள் அந்த appetite திரும்ப ரீகெயின் ஆகுமா, இல்லை அந்த அப்படியே ஃபாலோ ஆகுமா? இட் வில் பி அடாப்டட் ஆர்?
Excellent question. So now again, obesity, as if you look up the obesity is like, BMI over 30 technically in India, or BMI over 27 with comorbidities. This drug is approved. So what happens is, when you're on this drug, your appetite is always going to be under control, right? As long as you're going to be on this drug. Now the huge challenge is avoiding rebound weight gain, right? And what happens when the drug is stopped? Now you might have seen the new reports which was published recently from also the author from the Oxford University, showing that once these drugs were stopped, patients started regaining weight. This is seen in all studies as well. So behavioral modification has to be done. This gets the job done. Of course, it starts the proceedings. It complements your lifestyle modification, right? You get faster results. But when you stop, you might want to taper these molecules down gradually, right? Gradually, and then stop, rather than abruptly stopping at a desired weight reduction. So taper and behavioral remodification happens like anything. Once you stop exercising, you gain weight, right? Similarly, even here, when you stop the drug, there is a chance of regaining weight, but your fat is going to be less. If you do some strength training, etc., you build your muscle, your metabolism is likely to also improve. they may be more mobile, they can actually burn energy faster. So if you do behavioral modification, take them in that direction, it certainly can be reduced and avoided.
So which means it's like a actual, it will boost up that weight loss process
Absolutely.
by incorporating the diet and exercise, everything.
Correct.
It is not the permanent fix, right?
Correct. It cannot be the only fix. GLP-1, if suppose they think that this is the magic pill, magic answer to everything, absolutely not. Because what is going to happen is if you're going to lose weight, remember that some part of your weight is also going to be lean mass, muscle, right? And think about this. When you stop the drug, you'll gain everything in fat, which means even that muscle that you lost is going to be replaced as fat. So that is going to be counterproductive, right? So this is going to kickstart the proceedings, but if you can complement it with good nutrition and exercise, particularly strength training, then you can preserve your lean mass, even perhaps build on it, and then finally you can taper this drug and stop. But nothing can compensate lifestyle modification. That's the permanent long-term fix.
Awesome, doctor. And one more, lot of social media influencers வந்து இதை பற்றி பேசுகிறாங்க எல்லாம் ஓகே. பட் ஆனால் நிறைய பேர் காமனாக பார்க்குறேன்னா இப்போது மெடிக்கல் ஷாப்லேயே வந்து மொஹஞ்சரோ அவைலபிள் ஹியர் அப்படின்னு சொல்லி நிறைய பிக்சர்ஸ்லாம் நிறைய சோஷியல் மீடியா, இது வந்து நம்ம குரோசின் எடுக்கிற மாதிரி வந்து எல்லாரும் வாங்கி இன்ஜெக்ட் பண்ணலாமா? இது வந்து கரெக்டாக டாக்டர் ப்ரிஸ்கிரைப் பண்ணி இதுக்குன்னு இப்போ ஒரு ஜிம் போனால் எப்படி நாங்கள் அசஸ்மெண்ட் பண்ணுறோம், டெக்ஸா ஸ்கேன் எடுக்கிறோம், அந்த மாதிரி ஒரு ப்ரொசீஜர், என்ன ப்ரொசீஜர் எடுத்து இதெல்லாம் பண்ணால் கரெக்டாக இருக்கும்?
Absolutely. So like in fact, today I was talking to the head India of Mounjaro. So he was in fact telling me that 28 to 30% of prescription, they don't even have data. That means we don't know where these medicines are being prescribed. That should be avoided at all cost. You know, people who want to lose 3, 4, 5 kgs only, this would in fact result in more muscle loss in those people, right? So you'll have to understand that you should have considerable amount of fat when you have to consider these injections. People who have just about 2 to 3 kgs to lose, 4 to 5 kgs to lose, these drugs again can be counterproductive because this muscle loss only will happen. So that should not be used in such scenarios. So please see a metabolic physician, get your blood workup done, understand what are the reasons for obesity, right? Obesity can be because of hypothyroidism, can be other factors. So all those have to be ruled out. And then yes, DEXA scan definitely gives you deeper insights. It tells you how much of visceral fat is there. Visceral fat is the more metabolically active fat. One part that obesity is a stigma, cosmetic, but the most important reason why we are addressing obesity is that we are reducing the visceral fat. Visceral fat is the fat around the organs. Those are the culprits because they release the inflammatory cytokines which result not only in metabolic diseases, but they are the culprits which actually result in clogging of your arteries, cardiovascular diseases, and so on and so forth. So definitely yes, abdominal girth gives you certain insights. DEXA scan, the bioimpedance analysis, the body scan also gives you the in-body, which is also approved by the US FDA, that also gives you data serially. DEXA scan you can do once, but the BIA, the advantage is you can also do serially. It takes only 2 to 3 minutes time, and you can also look at the muscle retention with that. What happens when you use the GLP-1? So serially, that is something that we do at Revivo Clinic as well. We serially monitor persons who are on GLP-1 whether they are losing muscle or not, because if there is higher amount of muscle loss, we in fact stop. We do not suggest GLP-1. But if there is a good amount of fat loss and if you are able to, retain muscle, or if there's very minimal muscle loss as expected in a lot of weight loss, lots more fat, less muscle, then it is fine. So that is something that also needs to be tracked in patients who are actually taking GLP-1.
ஸோ மக்களே சிக்ஸ் பேக் தெரியல அப்படின்றதுக்காக ஜிஎல்பி மோஞ்சாரோ இதெல்லாம் எடுக்கிறீங்க அப்படின்னா உங்களுக்கு மசில் லாஸ் தான் ஆகும். இதை நல்லா கேட்டுக்கோங்க. அண்ட் ஆட் ஆன் டு தட், இப்போ ஓகே யூ செட் தெர் இஸ் லாட் ஆஃப் டேட்டாஸ் வாஸ் நாட் தேர், விச் மீன்ஸ் ப்ரிஸ்கிரிப்ஷன் இல்லாமல் அதை எடுத்திருக்காங்க. இது ஓவர் டோஸ் எடுத்தால் என்ன ஆகும்?
Right. First, there are a lot of contraindications. The contraindications, like people who may have some kind of thyroid cancers, family history, it is actually contraindicated. Patients who have history of pancreatitis, it is contraindicated. Now, the dosing is also extremely important because the dosing starts from, say, 2.5 milligram for tirzepatide goes up to 15 milligram, 0.25 of semaglutide goes up to about 2.4 milligram, right? Now, dosing is so important because I've seen people stepping up the dose because they want such fast results, right? Because everything is like reels today. Everything, they're so impatient, right? They think higher dose straight away for higher amount of. But think about this, when you have super fast reduction is also not good. Not good for your metabolism. The likely chance of regaining is also there. So the dose has to be appropriately initiated and up-titrated only by an expert metabolic physician who understands, okay, there is a reason that the dose has to be up-titrated. So please use with a proper clinician who's guiding you, because I've seen this kind of use, and I'm already seeing, because this Mounjaro has been there for 9-10 months, I'm already seeing people who bumped their fingers, who had all kind of side effects because of faster up titration and losing a lot of muscle, getting haggard. All this is happening. So this should be avoided.
ஓகே டாக்டர், ஒன் மோர் திங். இதுக்கு ஏஜ் லிமிட் இருக்கா? இது இப்போது நிறைய பேரண்ட்ஸ் வந்து வி பீன் டீலிங் வித் லாட் ஆஃப் பேரண்ட்ஸ், பிகாஸ் பேரண்ட்ஸ் தே நெவர் டன் எக்ஸசைஸ் பிஃபோர், சரிங்களா? பட் பிகாஸ் ஆஃப் சோஷியல் மீடியா அண்ட் ஆல் திஸ் இன்ஸ்பிரேஷனல் cricket players especially, they see all of them and they want their children to also be like that. Again, we generally say that to children's boss, you have to choose your parents a little bit more, because genetics plays a very crucial role in order to come, as in like when you go into any sport. அந்த மாதிரி போகும்போது sometimes there are additional pressure on children when they are little overweight. So parents, is there any age limit to start this kind of thing, or is it like anyone can able to use it? Like, how is it?
Excellent question again. So there is a trial called STEP Teens trial. So for adolescents, semaglutide has been studied and it has been approved by the US FDA, but there is no approval in India. So in India, it cannot be used in adolescents and teenagers. Maybe if the regulatory approvals give in the future, yes. But having said all that, I think this is the age group where we want to reiterate the importance of lifestyle modification, motivate children to adopt to a healthy lifestyle. I think we should not encourage children and adolescents to start with these drugs. But in India, it is approved over the age of 18 years.
அண்ட் ஒன் மோர் திங், இப்போது சில பேர் வந்து தே ஆர் ஓவர் வெயிட். ஃபார் எக்ஸாம்பிள், என் ஃப்ரெண்டே ஒருத்தர் வந்து லைக் ஹீ நெவர் டன் எனி எக்ஸசைஸ், எனி ஸ்போர்ட், இந்த மாதிரி மெடிசன் வந்திருக்கு, நான் போய் ட்ரை பண்ண போகிறேன் அப்படின்ற மாதிரி சொல்கிறாங்க. ஸோ வாட் யூ வுட் சஜஸ்ட் ஃபார் தெம், ஸோ ஹூ டசன்ட் வாண்ட் டு டூ எனி எக்ஸசைஸ், ஒன்லி டிபெண்ட் ஆன் த மெடிசன்?
So first time when they come to me, when they discuss about the GLP-1, I ask them, are you committed, motivated to stick to a healthy lifestyle? If not, I don't even encourage them to take this drug, because this is not going to do them any good, right? This can kickstart the proceedings. It can perhaps even accelerate the journey. But this is just one part of the puzzle in most people, right? In most patients, probably where they've tried everything, but at some point in time, they need a little bit of adjunct support. It is a great molecule. In patients who are extremely obese, they want a little faster results, they want to be little motivated, again, fantastic. But if they are not going to do any lifestyle modification, if they are not going to stick to a good nutrition, if they're not going to exercise, this is absolutely useless, because once you stop, you're going to gain back all the weight.
அண்ட் ஒன் மோர் இம்பார்ட்டன்ட் கொஸ்டின். இப்போது எல்லா ட்ரக்குக்குமே ஒரு சைட் எஃபெக்ட்ஸ் இருக்கும். வி டிஸ்கஸ்ட் அபவுட் ஆல் தட். பீப்புள் ஹூ ஹேஸ் ஆல்ரெடி சம் அதர் இஷ்யூஸ், தே ஹேவ் அ ப்ரீ எக்ஸிஸ்டிங் மெடிக்கல் கண்டிஷன், இவங்கெல்லாம் இந்த திரும்பியே பார்க்கக்கூடாது அப்படின்னா தெர் ஆர் வில் செட் ஆஃப் திங்ஸ் இல்லையா? அந்த மாதிரி வாட் டு யூ see?
Certain cancers are absolute contraindications, multiple endocrine neoplasia 2 and thyroid medullary carcinoma. These are absolute contraindications. Pancreatitis used to be an absolute contraindication. Now still it is a relative contraindication. It should not be considered in patients with a history of pancreatitis. Gastropathy, gastroparesis, already when they have a very slow digestion, அப்போ போய் நம்ம இந்த மருந்து கொடுத்தோம்னா இன்னும் நாசியா, வாமிட்டிங்லாம் இன்னும் மோசமாயிடும். ஆல்ரெடி பீப்புள் who have gut issues etc. has to be avoided. And patients who have retinal diseases, hyperproliferative retinopathy, there it can worsen the retinopathy status in patients with diabetes. In these subjects also, it has to be avoided.
Okay, as you said, gut issues. இப்போ இருக்கிற மெஜாரிட்டி ஆஃப் பீப்புளுக்கு gut issues இருக்கு. லைக் எவ்ரி ஒன் வி ட்ரீட். ஸோ ஃபஸ்ட்டு கட் ஹெல்த் ஓரளவுக்கு எங்களுக்கு தெரிஞ்ச அளவுக்கு அசஸ் பண்ணிவிட்டு தென் வி வில் ஸ்டார்ட் வித் ட்ரைனிங் டு ஹேவ் அ குட் அமௌண்ட் ஆஃப் ரிசல்ட். ஸோ அப்படி இருக்கும்போது வென் மெஜாரிட்டி ஆஃப் people is having a gut issue, how do you treat them and what are the tests you do? And
Correct. Very good question, because gut is the place where the incretins are also released, and gut is the main place where patients have a little bit of discomfort when we start these drugs, right? Each of the molecules will have subtle differences in the symptoms. Tirzepatide can have a little bit of diarrhea, for instance, and semaglutide, you will have a little bit of bloating and nausea. Very rarely you can even see patients who have vomiting, right? So all related to the gut. Interestingly, in patients who have inflammatory bowel diseases, studies have shown it actually kind of slightly improved because these drugs are also anti-inflammatory.
Oh.
So it's slightly improved in certain conditions. However, patients who have very severe acid peptic disease, already gastroparesis, I said, their patients struggle. So there we'll have to be very, very careful. In fact, patients who have repeated gastritis, you have to tell them this drug can cause this, and start with the lowest dose, see if they tolerate it. If they don't tolerate it, then we'll have to, in fact, avoid. But inflammatory bowel diseases, this drug has been helpful. In gastroparesis, gastropathy, this drug has to be avoided. How do we find out whether gastroparesis is there? First, we check through an endoscopy. In patients who have gastroparesis, we see whether there's any mechanical obstruction. Otherwise, there is a technetium scan, like a tracer. We see whether after giving some food, whether how long it takes for digestion. So there is a specific test for it. So if there is no gastroparesis, then they are safe. I mean, this is not routinely done for everyone, but patients who have symptoms of gastroparesis, we can do this test and then decide whether to give this agent or not.
One more question. The women's, especially post 40s, who've been struggling with menopause, severe menopause, can this drug help them to get the whatever the weight loss they've been looking for? Can be used in that particular, because all the hormones is in very bad imbalanced state. Can it be a slight kind of a what do you call it? It's like stimulus.
Yeah, right word. So yes, most certainly yes, because as we know, the resting metabolism rate, everything comes down as patients' age advances, right? It does give them, it kickstarts, as I said, accelerates that process of weight loss. Some people I see who are motivated with good lifestyle, motivated for a good lifestyle modification, who adhere to a good exercise. In fact, it benefits them because they see better results. They're able to be on track better. Because you need results to also stay in course, right? So those people, in fact, maximum benefit, and these are the people we can also taper and stop the drug. Yes, postmenopausal, definitely this can play a role, especially in people who want to lose weight with good lifestyle. I'm reiterating because lifestyle modification is so important.
And one more thing I just wanted to reiterate is because it is not one man job, I guess, because when we talk is about a trainer who can able to understand, empathize client in terms of exercise, nutrition and all the aspect of them. And when it comes to medical and clinical aspect, it has to be done by a doctor. It should not be done by influencer. It should not be done by some random people who just because we've been seeing a lot of people, they do some sort of a weight loss journey, they will put one, they'll become second day, they'll become trainer, and whatever worked for them doesn't mean it works for everyone. Like how we all look very different from outside, the functions also very different from inside. So I think everyone should understand how their body works. First go and consult a physician. And when you wanted to try a drug or when you wanted to go and do exercise, have one consultation with an expert, with a doctor, with a trainer. Then if you want to do something, then I think it makes more sense, rather than, I think last week there is one girl passed away.
Correct.
Your YouTube path, she had some so there are a lot of things that are going on. Unfortunately, the things are happening. I think the illiteracy, fitness illiteracy is going on. Too much of information is going on and thing. So having எது கரெக்ட் எது தப்பு அப்படின்றது தெரியறதுக்கு ஒரு எக்ஸ்பர்ட்டை போய் கரெக்டாக போய் கேட்கறது, I think is the best solution for you, rather than you yourself asking asking your AI, ChatGPT, or going on to your social media, I think.
Absolutely agreed. Well said.
தேங்க்யூ ஸோ மச் டாக்டர். ஆக்சுவலி நீ வந்து பாயிண்ட் பிளாங்க் எல்லாத்துக்கும் வந்து இதான் ஷார்ப்பாக சொல்லிட்டீங்க. தேங்க்யூ ஸோ மச் ஃபார் கிவிங் திஸ் டைம், வேல்யூபிள் டைம். தேங்க்யூ.
Indeed, pleasure. Pleasure is mine.